Now, like again in pulmonary sinuses, there are so many surgical options for perianal fistula. Now, if you were to ask your surgeon, why do you have so many options for this particular condition? The simple answer is many of these surgical conditions do have a failure rate. And that is why the surgeons have over the time come up with different options for perianal fistula. Now, the classic operation for a perianal fistula is called laying opening. So that involves laying opening of the tract of the fistula. Now, this gives the best chance of cure, 95% chance of cure. However, if the surgeon was to perform this, the fistula need to be below the sphincter complex of your anus. Now, in our anus, there are two muscles, one outside, one inside. The outside gives us the conscious continence, but the inside one gives us the unconscious continence. Now, if you do any damage to these sphincters at the time of a fistula operation, then of course one is at risk of incontinence. Traditional surgical teaching will tell that about a third of the internal sphincter can be sacrificed. But most of the neurosurgeons, like myself, we would not want to do that because of the chance of incontinence. So in my practice, if the sphincter is, if the fistula lies below the sphincter, or if it is only involving a very minimal amount of the fistula, of the sphincter, only I would be able to lay it open. Now, if it cannot be laid open as such, then of course there are other options. One classic option is the video-assisted anal fistula treatment, or we call it the WAFT operation. Now, that carries a 30% chance of recurrence, but what it means is 70% chance of cure. The advantage of the WAFT is because we don't do any incisions, we are not going to damage the sphincters. And of course, because there are no more incision, even if it fails, we can always go for another go at a later date to attempt a cure. Sometimes one might need a couple of sessions before we achieve a cure. Now, the WAFT involves going through the outside hole to clean the tracts and treat them from inside, and also to close the internal orifice. And then, of course, there is another option called lift procedure, which stands for ligation of the intersphincteric tract. This could be a standalone procedure, or it could be a procedure as part of other procedures, like, for instance, an EPSIT. What it means is that the fistulous tract, when they cross those two muscles that I mentioned, the outside and the inside, they can be caught in between the two, and then it could be ligated, so it can be disconnected from the rectum. Then, of course, if none can be offered, then of course one option is what is called a seton thread. Seton thread is essentially a thread that goes along the fistula and then tied outside the anus. There are two types of seton called cutting as well as drainage. What is commonly used is the drainage seton, which let the fistula drain outside, preventing any accumulation inside. And the advantage of that is that will make the incision go away on one side, and also it will let the fistula tract mature so that the surgeon can do a definitive procedure like a WAFT or a lift procedure on another day. Cutting setons were used in the past to offer a gradual cutting of the muscles, so that there is time for fibrosis to develop. That's not been used so frequently now because of pain. And then there had been so many other attempts right throughout the history, like glue or plugs or fibrin sealants, etc., etc. They have, in fact, to be honest with you, have gone out of favor because of higher failure rates. So those are the options for a perianal fistula. I think the important thing for you to do is to have an honest chat with your surgeon as to what would be the best option for you. Now, this depends on the fistula configuration. What kind of a fistula have you got, and how is it configured around your anus, and what is its relationship to the anal sphincter complex would be the primary thing. And also your body habitus, your previous operations, and what has failed so far in your case would also determine what you're going to have. you should always try and have a discussion with your surgeon as to what is the chance of recurrence or success in this procedure, because it is very important that you understand that this is a procedure with a chance of failure, and you need to be on board with your surgeon about the success rates. And also you should have a discussion with your surgeon as to what is the expected aftercare after these procedures, because you will end up having to look after the wound, your fistula, after the procedure until it heals. Most of the fistula operations will take about 30 to 40 minutes. They're performed as day operations, meaning you come, get it done, and go home the same day. Now, these procedures are done under general anesthesia because otherwise they are so painful. As such, you need to be accompanied by someone home, and then an adult need to be there with you for 24 hours at least. And of course, you'll be out of action for about 2 weeks if you have any incisions on it. But of course, if you had a waft operation, then you'll be back doing your normal duties after about 2 to 3 days. There's not much of looking after you need if you do have a fistula operation. Now, if you do have a lay opening of a fistula, then of course the wound need to be dressed. It will be every other day to start with. And that will be by your GP until it heals, and this will take a few weeks. But if you do have a waft procedure, then the wound need to be syringed with saline. In my practice, I normally give the syringes as well as saline vials. The syringe has a nozzle. The nozzle goes into the hole, and it need to be syringed with saline in the morning after going to the toilet and opening your bowels and cleaning yourself, and again at bedtime. So twice a day for 10 days. It's part of the treatment, and it's very important that you do it that way. Now, obviously, because you can't see it, someone at your household will have to do it for yourself. And of course, you need to expect some oozing for about 6 to 8 weeks. It's part of the expected recovery, and during this time, I normally advise patients to wear a cheap absorptive pad so that your underpants don't get wet. Now, if you do have a seton, then it can be sometimes painful because you're going to feel it there. So taking regular pain relief would be good. And most of the setons, because they are only temporary measures, and because they are only used as a precursor to a previous one, then of course you might need a second procedure after your 3 months review. In any respect, you will expect a review at your surgeon's office again in about 3 months' time to see whether you have settled or to see whether you need any second procedures.